A warm welcome to everyone who has joined in. My name is Mohammed Usman. I'm one of the co-founders of PharmaSense, and I'll be your chair today. Our speakers include Sarwar and Nabeel, who are also co-founders of PharmaSense, and I'm excited to announce our two guest speakers, Aiysha and Ayat. I will be asking all the speakers to introduce themselves shortly. Now, firstly, I'd like to start off by recognising the significant contribution pre-regs have made during this pandemic. It has not gone unnoticed by our team at PharmaSense, as we're currently in contact with many pre-regs across the country, and we have felt connected throughout the process. Often we're taken to social media to voice opinions, and once the announcement was made for provisional registration, we felt like it was necessary to host this webinar in order to share our advice on how to cope with such a transition. By the end of this webinar, hopefully our viewers will develop a greater understanding on how to manage being a day one pharmacist and what they can do before and after day one in order to continue professional development. We've already received multiple questions that we will hopefully address throughout the webinar. We would encourage everyone to send any questions they may have for the Q&A session at the end. For those who haven't used Microsoft Teams before, you can do this by clicking on the icon which has two speech boxes, one of which has a question mark. I'm now going to pass on to our speakers for a quick introduction, starting off with Sarwar.
Hi there, everyone. My name's Sarwar Shah, and I'm a newly qualified clinical pharmacist and also a co-founder of PharmaSense alongside Nabeel. First and foremost, I want to reiterate what Usman said. We understand how hard it's been for you guys throughout this pre-registration period. It's been very different to everyone else, and we admire the work you've been doing, and we want you to know you have the full support of us pharmacists and the PharmaSense team behind you as well. Okay, so just a bit of a background about myself. So as I said, I'm a newly qualified pharmacist. I studied at the University of Bradford, where I did the MPharm sandwich course. So this course is a little different to other courses out there, wherein you do a 5-year university course and you do 6 months of pre-reg split into your 3rd year and your final year. So in my pre-registration, I did my first lot of 6 months at Boots Pharmacy. So I learned a lot of things about the over-the-counter conditions. I led the team, dealt with queries. I made the most of it. So I built rapport with patients and made sure to liaise with the substance misuse teams and the local surgeries. So my second lot of pre-reg period was in my final year of uni. And I did this at CHFT, which is Calderdale and Huddersfield NHS Foundation Trust. So I really loved this experience, and I rotated through various specialities, including medical wards, surgical wards, mental health trust I participated in as well. I was very fortunate enough during my time at CHFT to spend time with specialist members of the team, such as diabetic nurses, cardiology teams, and also watched procedures happening and operations occur as well. My favourite rotation while I was at CHFT was gastro, where I worked with a pharmacist called Mohammed, which I'll discuss a bit about later. Also, alongside the MPharm course and during my pre-registration period, I developed PharmaSense with Usman and Nabeel. So just a bit about the work we've done. We lead pre-reg training days, mock exams, and also conduct OSCE training workshops, which Nabeel will mention a bit more later. Through this work, PharmaSense, we've been awarded a couple of awards. So the RPS Award for Most Outstanding Contribution to the Pharmacy Service, and also the Bradford University Award for Joyce Keeney Prize for the Most Outstanding Contribution to Bradford University. I'll now currently then, as a newly qualified pharmacist, I've been working as a rotational clinical pharmacist at Pennine Acute Trust. This includes working on calls, covering maternity wards, surgical wards, medical wards, and I also locum in community quite a lot as well to make sure I'm competent within that area. So I'll pass it on to Usman now.
Thank you, Sarwar, for that introduction. Next speaker is Nabeel.
Hi everyone, my name is Nabeel. Like Sarwar, I'm a newly qualified pharmacist. I too studied at the University of Bradford, but I was on the continuous course like most people are. So that's the 4-year MPharm degree, followed by a 12 months pre-registration placement and then the pre-registration exam leading to qualification as a pharmacist. So just a bit of background about myself in regards to my pre-registration background. So I was part of the first cohort that was involved in the oral process, which is quite interesting, and I managed to secure a place at my first choice, which was Bradford Teaching Hospitals. I spent 12 months at Bradford Teaching Hospitals, where I had various rotational placements, a lot of which were split into clinical and service-related placements. Clinical placements including acute medicine, renal medicine, cardiology, surgical wards, and in regards to service rotations, I was involved with medicines information, where pharmacists deal with queries and provide research-based, evidence-based answers to those for other healthcare professionals and patients alike. I also was able to. I had a service rotation in aseptics and quality assurance, where I was able to formulate stability profiles in relation to aseptically prepared products as well. I was also fortunate to have a mental health rotation as well, which was with Linfield Mount Hospital, which was an invaluable experience in itself, just because I was able to see a pharmacist role within quite involved within an MDT in regards to patient-centered care in relation to mental health. I was also involved. I also had the opportunity to do a cross-sector placement in community pharmacy. So prior to my pre-reg, I had previously worked in community pharmacy as well, but again, it was more related to a dispensary related role. So this time around, I was able to work as a pre-registration pharmacist. I've also been able to have a cross-sector placement in general practice as well, which was quite interesting, especially in regards to the evolving roles of pharmacists within primary care. I was able to see and shadow different members of the primary care teams, including doctors, nurses, pharmacists, especially your prescribing pharmacists, and those that are advanced clinical pharmacists as well, leading consultations. I was also involved in doing an audit as well as part of the GPHC framework for my trust. My audit was in relation to chemotherapy workflow, identifying bottlenecks within the process itself, and finding ways to overcome that as well, and implementing solutions as well, which was quite beneficial for the trust itself. So just going on to PharmaSense, as Sarwar's mentioned, PharmaSense was something that we'd created as pre-regis ourselves, and we found it quite useful because we studied at the University of Bradford. We had a lot of team-based learning. That was the setup initially. So it was something that we wanted to foster with our peers and formulate a peer support network, and that's exactly what we did. So we started off with WhatsApp groups where we were able to share our own experiences during pre-registration. So with our community peers or the hospital peers, and again, it was a useful resource as well in regards to revision as well, and staying up to date with the knowledge in regards to the pre-registration exam as well. Moving on to the OSCE training workshops that we've done. So we've done a lot of OSCE training workshops. This was especially beneficial for ourselves and for students that we taught in the years below. I say this because once we had done our OSCE training and had our OSCE exams, we were able to see how these skills worked in practice, and then we were able to adapt them in practice and then bring them back to the students, and been able to show them what we had learned from it as well. So I'm just going to move on to my role as a newly qualified pharmacist. I'm currently a bank pharmacist at Bradford Royal Infirmary as well, and again, I'm also a Locum community pharmacist as well. So I'm trying to keep my hands in both as well in regards to experience as well. I'm just going to pass you back over to Usman.
Thank you for that, Nabeel. Now our next two guests, speakers are our guest speakers, and that's Aiysha and Ayat. So I'm going to start off with Aiysha, please, if you can introduce yourself.
Good evening, everyone. So a little about my educational background. I undertook my MPharm at the University of Nottingham, and like Nabeel, I was on the traditional 4-year programme. I've been quite involved with education and training during my undergraduate years, both with the school and the RPS, and then as well with the Student Union's Education Network. I was lucky in that my undergraduate research was published in the Journal of Pharmacy and Pharmacology, which was an incredibly exciting experience, as I was able to present that at the RPS in London. I was also the founder of the Pharmacy Education Charity, also known as the PharmEd Charity. So as I've said, I've been quite involved in education and training throughout my undergraduate time, and I'm still very involved as a newly qualified pharmacist, which was actually made coming onto this webinar quite easy, as PharmaSense has been so committed to education and training, and to be honest, it has been quite inspiring. So heading on to my pre-registration time, I undertook my pre-registration training year at the Leeds teaching hospitals. It was an incredible training year, and the programme really exposed me to a variety of rotations. Some of the ones that really stuck out and have stayed with me have been oncology, haematology, and neurosurgery. And what I really enjoyed here was how involved the pharmacist is in treatment and the long-term care of patients. For my cross-sector experiences, so I also took my cross-sector in mental health. This was in Leeds and York partnership. I also did a community pharmacy placement for 2 weeks, and I organised my own GP practice experience during pre-reg. I undertook some audit work during my pre-reg year, and this was presented with the others at the Yorkshire and Humber pre-registration study days, and I was actually awarded the runner-up prize for my research. So moving on to my current role, I am a newly qualified pharmacist in primary care, so I work for the Leeds GP Confederation. So I'm a foundation clinical pharmacist, and I'm looking after my own PCN, and I support other practices who are part of a wider collaborative organisation. I'm also on the Pharmacy and Education Training Working Group at the Confederation. So some of our recent work has been involved with increasing engagement with the pharmacy schools. And I've just recently finished some oral resources for universities on the 3 pre-reg programmes we offer to help the current undergrads who are struggling due to COVID and unable to get this exposure and understand what we all provide. I'm undertaking my MSc in Foundation Pharmacy Practice at the University of Bradford. This is actually a new programme in the fact that all sectors are combined. So I'm undertaking my MSc with people from community and hospital, and this has been really interesting for us all to work together. Alongside my main role, I also sit on the NHS Leeds CCG BAME network. This committee is really hardworking, and one of the recent pieces of work we've actually been doing is on COVID-19 BAME risk assessment documents, and this has actually been used wider side of BAME as well. I will also be commencing my primary care pharmacy education pathway in the coming weeks with CPPE. I'll now hand it back to Usman. Thank you.
Thank you, Aiysha. And our final speaker, Ayat.
Good evening, everyone. Thank you very much for inviting me to speak, Sarwar, Nabeel and Usman. It's a pleasure. So for those of you who don't know me, I again did the Bradford 5-year sandwich course, which meant that I had 2 sets of pre-registration placements. So I had 6 months at Boots and 6 months at Leeds Teaching Hospitals, which is where I met Aiysha actually. So at Leeds Teaching Hospitals, because it was a smaller rotation, it was only 6 months, I had some experience in mental health, in gastro, respiratory and admissions. And I also had some experience in the liver clinic as well, which was actually quite interesting because it's very MDT orientated, and it dealt with a lot of liver transplants, specifically in children, so that was very interesting. My audit was regarding discharge reconciliation, and essentially it was assessing whether or not, as a trust, do we reconcile medications on discharge correctly. So it means, in a sense, of medications that were changed during admissions, are these communicated clearly on discharge to the GP to prevent further medication errors that might occur in the community. So my current roles as a newly qualified pharmacist, I'm currently a shift working pharmacist or resident pharmacist at Nottingham University Hospitals, NHS Trust. Currently I am on 3 monthly clinical rotations, and this spans over 2 to 3 years. So some of the rotations that I've been fortunate to experience is healthcare of the elderly, surgery, specifically orthopedic and elective surgery. I'm currently on respiratory, and I've also had some experience with step down wards from COVID-19, so patients that have been in intensive care and then are now step down. So I've had some experience there as well. Part of the shift working pharmacist is the on-call commitments as well. So Nottingham University Hospital spans over 2 hospitals, and it's a very, very large teaching hospital. So the on-call service is probably one of the busiest that you're going to get in the country. So it is very demanding, and but at the same time you learn a lot, and it's an incredible experience. I'm also involved in some medicines management technician training, so I've been involved in creating objectives and ward visits for them. Also locum on the side, very rarely, but I do like to keep my foot in community as much as I can. So on average I'll do about 1 to 2 shifts a month. I'm also enrolled onto the MSc in Clinical Pharmacy, which is the clinical diploma with De Montfort University. This is a distant learning programme, so I only have 1 or 2 study days a year. The majority of the learning is done in-house or online. Most recently, I've been a keynote speaker at an international virtual conference on COVID-19. A lot of my interest in COVID-19 did occur when I was covering those wards. I just found it incredibly interesting. So as a result, I've then gone on to do a bit more research, and I've given 2 talks. The titles were the UK's government response to COVID-19, and the second was exploring the current treatment options in clinical trials. So that was mainly discussing immunomodulators, the steroids as well. So as you know, if you've seen in the media, dexamethasone has now been approved. So those clinical trials have been useful in that sense. And on the side, I also am a executive member for a youth foundation charity in Manchester, and have been for as long as I can remember. But currently I work remotely with them, and I'm a volunteers coordinator with them. Thank you very much.
Thank you for that, Ayat. I'd like to thank all the speakers for introducing themselves. And as we can see, they've accomplished a vast amount in such a short space of time. And given that they're newly qualified pharmacists, we felt like they could relate to pre-regs going through this process now. So the next topic that we would like to discuss is cross-sector placements. Now, we had a lot of questions coming in regards to cross-sector placements. A lot of people missed out on the opportunities due to COVID-19 and had to sacrifice these placements. So we're going to ask each of the speakers to go through their cross-sector placements, just so we can fill that void, so to speak. First section that we would like to go over is mental health, and that's Ayat.
Yeah, so one of my sectors that I worked with as a pre-reg was mental health, like I said. So for those of you that know, in Leeds there is a large mental health trust that deals with a lot of complex mental health issues. So there is a specific anorexia section, which I didn't actually go and visit. Aiysha visited, but it is very interesting. I was based on a ward that dealt with a lot of bipolar, suicidal ideation, and chronic depression, really, and we had quite complex patients there that were on antipsychotics as well. So the main thing that I wanted to kind of touch on with mental health is you're not at a disadvantage because you haven't had a mental health placement. It's very simply with mental health, it's very heavily MDT focused. So in that sense, it was quite useful to see how much a pharmacist can have, how much their input is valued in an MDT setting. Now, you will obviously see MDT, if you go into hospital, for example, you will see MDTs happening. However, they are very, it depends on the sector that you're working in terms of how involved a pharmacist is. Obviously, we do try to be as involved as possible. However, with mental health, you are very, very involved. Pharmacy is pivotal to decisions in care. As you all know, CNS is a high weighting chapter. My advice would be to ensure you split the chapters and review individually rather than review the whole chapter together, because it is quite daunting and the chapters in there are significant. But just in terms of my experience, yeah, like I said, so it was heavily MDT focused. We would discuss a lot of the antipsychotics there in terms of monitoring LFTs, lipids, blood glucose, a lot of ECG monitoring as well. As many of the medications that the patients were on caused QT prolongation, and as a result we had to be very careful as to what we were adding and stopping with regards to their medication regimen. So from a mental health perspective, the only thing I could really say is that it is very heavily MDT focused. It's a valuable experience to have. So even if you are going into your provisionally registered places, there is still that opportunity to arrange your own experience if you can. Just because you're no longer a pre-reg doesn't mean you don't get to experience these things. So if you are specifically interested in it, I would say reach out to those areas and just say, I'd like a day or two. Even a day is more than enough to experience what they do and just to grasp the impact that mental health pharmacists have. So yeah, that's what I wanted to say. Thank you.
Thank you for that, Ayat. Some excellent insight into mental health placements. The next placement that we want to go into is community placement, and I'll ask Sarwar to speak, please.
Yeah, so as Usman said previously, it's very important to be aware of the roles and responsibilities of pharmacists in multiple sectors. It is a shame that a lot of you would have missed out. So my plan is just to discuss a little bit about the community sector for those working in mental health, primary care and secondary care, just to see what you would have missed out on and what you should really go over prior to the examination, and if you are moving into that sector. So community sector is quite different in a sense where you are going to be the clear leader of the team. Everyone will look at you for leadership, for support, and you are the responsible pharmacist of the pharmacy. Another key thing that you would have missed out on is OTC conditions. So this is important to know both for practice and the exam. So my advice would be for those that missed out on the community placement, make sure you read over NHS choices and over-the-counter books such as Blenkin SOPs, responding to symptoms, learn your red flags and learn your age ranges as well for P medicines. A good way to learn these things is using the SMPC. Also, another thing that you may have missed out on would be the responsible pharmacist laws and rulings, as it differs in primary care and obviously in hospital. So to read over this, we would advise going over the MEP, sorry. Also, it's important to learn about emergency hormonal contraception, both for practice and the exam. If you missed out on a cross-sector placement, what you can do to develop your learning and understanding in this area is use the RPS EHC guidance, which is quite good, and also the CPPE EHC course. Also in community, it may be a lot more accuracy checking and clinically checking that you're doing under and dealing with queries and questions. And one thing that those from primary care and secondary care will find very different is you are clinically checking with a lot less information, so you won't have indications and bloods and things like that. So that is something that you will have to get used to as well. And leadership is another key thing that you will have to develop to get into this sector as well. I'll pass it over to Usman now.
Thank you for that, Sarwar. The next cross-sector experience that we want to talk about is hospital placements, and I'll ask Nabeel to speak, please.
Right, so in regards to hospital pharmacy, so because I spent a whole 12 months in hospital, I can sort of talk you through the day-to-day activities that I was involved with as a pre-registration pharmacist, and a lot of it is transferable to when you do qualify as a newly qualified pharmacist, or even as a provisionally registered pharmacist. Sorry. So some of the day-to-day tasks involve medication reconciliation. So this is something that you most likely would have learned throughout university, especially in regards to OSCEs and whatnot. So yeah, medication history taking is the bread and butter, especially in regards to ward-related tasks. So obviously compiling histories, reconciling them against the drug charts, spotting any issues in regards to ward round plans that the medical team have made, in regards to any other inputs, so anything in regards to nursing concerns, anything to do with salt reviews, so that's if patients are struggling to swallow, and anything, and looking at the patient holistically and with a focus in regards to their medication as well. And obviously, once you'd reconcile this and you look to have these discussions with prescribers and have amendments put in place as well. And a lot of this, you know, as a pharmacist, contrary to what obviously Sarwar said in regards to community pharmacy, in hospital pharmacy you do have a wide range of resources as well. You've got a lot of monitoring parameters for each patient, so a lot of the times you'll not only have the drug chart available, you'll have the their blood results available, so you'd be able to look at the patient's infection markers. You'd be able to look at look at whether they've got any degree of renal impairment, calculate their creatinine clearance, liver impairment, CRP. You'd be able to look at vital signs, etc. And you can look at that in relation to their medication and make decisions in regards to whether the medication the patient is on is suitable for them, whether they need a dose reduction, or whether you can really optimize treatment and therapy as well. Aside to that, so that's the sort of bread and butter on the wards. You will be dealing with inpatient orders, so that's ordering medication for patients while they're an inpatient, screening TTOs as well. So we call them TTOs, but they're also known as discharge summaries as well. So when a patient's going home, so reconciling that as well and making sure the patient's got their medication. And in regards to ward queries as well, so you really do, as a hospital pre-reg and as a hospital pharmacist, you really do help in regards to the logistical side of patient transfer of care as well. So there is a lot of you liaise a lot with the ward teams as well in regards to transfer of patients as well. In regards to hospital pharmacy as well, there's the service side of it as well. So I did briefly touch up on the on aseptics. So I did an aseptic rotation, and on there I was able to compile stability profiles for aseptically prepared medication as well. So that took a lot of research related. It's a research related task where you're looking at SPCs and different resources as well, and compiling that information and setting a suitable stability profile for a specific drug. I also had rotations including medicines information, which I think was a vital rotation for myself, especially. It has helped me as a newly qualified pharmacist, and especially on the wards as well. So medicines information is obviously it's dealing with queries, more specific queries in relation to patients, looking at different resources and compiling an answer, and giving that. Providing the answer to prescribers or patients alike as well. So I'll just pass you back over to Usman.
Thank you for that fantastic insight into hospital placements. The next cross-sector placement experience that we want to talk about is primary care, and passing that over to Aiysha.
I just want to pick back up from what Nabeel said. You are core to as a pre-reg, you are core to the team, and that is the same in primary care. You will find as a pre-reg. You don't ever see yourself as just a pre-reg. You are core to that MDT. When I've been in primary care myself, and when I've seen the pre-regs now, they have been so involved. Some of the things you would have experienced would be being involved in medication reviews, helping with polypharmacy. You would be supporting the pharmacist and be given some tasks to do yourself. Some of these things are areas like researching, looking into the patient records and looking into the system to see where patients weren't being followed up properly, if there was patients that needed cover on top of the current medication they've got. So this could be stuff like PPIs and NSAIDs. Some things that I think that you'd find useful if you had done these pre-reg placements is things like queries on renal medications. So a resource I used quite well during pre-reg, when I did my pre-reg primary care placement, and I've seen the current pre-regs use, is Think Kidneys. I think it's been fantastic even now when I've been qualified in regards to renal medication, and this is something the doctors and the MDT team do come to the pharmacist for. Another is you will be reviewing a lot to do with medications that cause falls and reviewing patients with increased falls and looking at the anticholinergic burden. Now, if you want to be looking at things to do with how you can carry on this revision now, if say you want to organise a placement later on, the West Essex CCG have a fantastic document on anticholinergic burden, and it shows you what medications might impair cognition, and cause falls. I just want to put out here that MDT is core in primary care. I know all the other sectors are involved in MDT, but in primary care, it is all MDT. We're not different teams. There's not the doctors, the nurse, the pharmacist. We are all one. And you've got the CCG commissioning team. You've got clinical pharmacists from other supporting teams who may not just be in your practice. You have the healthcare assistants. You have the mental health primary care liaison teams. Now, I want to link this back in with what Ayat said. In mental health hospitals, that is where you're going to be looking at drugs like clozapine, which is very important for when you do your exam revision, when you're working as provisionally registered pharmacist on day one. Now, all the clozapines initiated in by the mental health specialist, we work really closely with the mental health primary care liaison team in following up these patients and looking at the long-term management. And what I want to add on here is, yes, this is an unprecedented time, but as Ayat said, if you want to be able to get some experience here, just get in contact with your local primary care organisations or the local practices that you see if you can arrange some volunteering, some shadowing, even if it's virtually, and that is how you will get that exposure to see if this is actually where you'd like to be and pick up on stuff even for the exam. I'll pass that over back to Usman.
Thank you, Aiysha, that was excellent. We hope that that section has helped to fill the void that you guys missed out on your cross-sector experiences. The next section of the webinar that we're moving on to now is the open discussion, and the open discussion will be a 3-part open discussion. Starting off with what preparation is essential for day one practice, and also what to expect on a day-to-day basis, across those sectors, and also what you guys can do as provisionally registered pharmacists to help maintain your knowledge towards a pre-reg examination. So the first section that we're going on to now is what preparation is essential for day one practice. And I'm going to pass over to Sarwar, and hopefully you can talk to us a bit about indemnity insurance.
So yeah, thank you, Usman. Yeah, so a part of the requirements to practice as a pharmacist from the GPHC is to have appropriate indemnity insurance in place. This is pretty much essential for all healthcare professionals that are working within any register. So the key thing about indemnity insurance is there's different indemnity insurances depending on whichever sector you are working in. Some employers do provide indemnity insurance in places such as hospitals and whatnot. However, the advice that's always been given to myself from seniors and my peers is always have your own indemnity insurance in place as well. For instance, for community pharmacy, I know the PDA are going to be providing insurance for provisionally registered pharmacists, and I think there will be other providers out there as well. Also, in primary care, you're usually not covered by the basic newly qualified pharmacist insurance. So you need to look at the finer details and contact the company or the primary care physician or the insurance provider and discuss with your workplace, because it's essential for you to have the correct cover in case anything does go wrong. I think that's all I can say about indemnity insurance, but there are tons of providers out there, and it's imperative that pre-regs need to have a look at this area as well.
Thank you, Sarwar. The next point I'd like to talk about is upskilling, so any potential courses that you may need to complete depending on what companies you work for. So I'll pass that over to Nabeel.
Right, so I just want to bring your attention to all the courses that are available, especially for those that are going to be practicing as provisionally registered pharmacists. So depending on what sector you end up in, so I'll speak initially based on the community sector. So as before I started locum as a pharmacist in the community sector, I was required to have completed certain courses which are available by the CPPE, and they are all free to access as well. And some of the courses are related to the responsible pharmacist module, a module on emergency hormonal contraception, medication use reviews, new medicine service, safeguarding, which is fairly important regardless of what sector you end up in. Another one for community would be repeat dispensing, oral health, sepsis, and being able to identify sepsis. So this is one that I think is valuable regardless of what sector you're working again. And one for summary care records, especially for community pharmacy and dementia friends potentially. But it all depends on your organisation that you will be working with as a provisionally registered pharmacist. So it's probably worth speaking to them yourselves and to figure out what they do require for you to have completed prior to starting. But again, CPPE is a brilliant resource just in regards to staying on top of your revision and testing yourselves as well, regardless of what sector you're in. If you were to go on there, they've got free courses in regards to minor ailments. So again, that's another good one for community pharmacy. They do have courses on anticoagulation. So again, that could be something for either community, hospital or primary care. And there is courses in relation to like discharge summaries, etc. So it is worth going onto there, making an account, having a good look around on there, and seeing what could help you develop in your practice as well, and again towards your revision, because obviously at some point you will most likely be sitting a registration exam as well. So it is worth helping you to stay on top of your knowledge.
Thank you for that, Nabeel. The next question I want to move on to, and I feel like this one's very imperative for provisionally registered pharmacists, is useful resources, so apps and potential websites that they could use across all the sectors we've discussed. So first, I'd like to start off by asking Ayat to mention a few resources that she may potentially use.
Yeah, so because of the rotations that I have been on, I have used two apps that have stood out for me quite a lot in my newly qualified year. What I would say was, with all of these resources that we are about to mention, it would be fairly useful if you were to download them now or check them out in your free time, just to kind of familiarize yourself with them, because they are very useful and they tend to make your day-to-day practice much easier. So the first one that I'm currently using quite a lot on the wards is Right Breathe. So Right Breathe is an app which essentially has all the inhalers possible all in one app. So what it essentially shows you is the inhaler, the active ingredients, what it looks like, which is actually more useful than you would think, because we get a lot of patients that come in, especially elderly patients that are either with COPD or asthma or bronchostasis, and they will say, oh, I take a yellow inhaler or I take the green inhaler, and sometimes it's worth just showing them a photo, a picture of the inhaler, and it makes your medicines reconciliation much easier. At the same time, this app also has a link to Right Breathe's YouTube channel, where they show you the techniques for inhaling the inhaler. So a lot of the times I will show my patients the video, especially the younger patients. So we get a lot of newly diagnosed asthmas, especially right now with all the high pollen and the humidity. It's quite common that we're getting them coming along. So I tend to use the app in that way. It's also useful in MDTs. So we have a lot of, depending on which region you're in, but we have a lot of doctors that may want to actually prescribe something that is more cost effective, which is actually very useful. It shouldn't always be money orientated. However, inhalers are quite expensive. So if you're there and you've got your resource and you can say, well, this inhaler has the exact same active ingredient as this other inhaler, maybe we can think about switching the patient to this and trialing that inhaler. You just become a bit more valuable, and you have something quite quickly to look at. It's also useful in community as well, just to distinguish which inhaler is which and to kind of counsel your patients, especially if they're started newly on inhalers. Another one that I do tend to use, because I was covering healthcare of the elderly, is the stop-start tool. Now, healthcare of the elderly, if you're lucky enough to have a rotation there, it is by far one of the most informative rotations I've ever had. The interventions that you can make as a pharmacist is incredible. As you can imagine, a lot of these patients are on a wide variety of medications. The issue of polypharmacy is very rife in that community, in the elderly. And a lot of times it's because their medications haven't been reviewed in the community, or they've just not, well, it's primarily because they haven't been reviewed, but it's not because of lack of reviews. It's just a lack of habit, basically, or a habit, I should say. So the stop-start tool has actually been newly integrated into the BNF, as far as I'm aware. So but it's been around for quite a while now, and it's quite useful to distinguish which medications may be causing more harm to an elderly patient, specifically those that are admitted with falls or anticholinergic burden. It's stuff like that that kind of helps, especially when you're on ward round, or even when you're just reviewing a chart, or you're reviewing a prescription and you're assessing that something might not be as useful in that age group. Instantly, if you see someone of an older age, you do start to think, okay, what's their renal function like? What medications are they on? For example, if you see a benzodiazepine in an elderly, you'd want to start questioning, how long have they been on this? Is it something that's really necessary? Are they benefiting from it? We don't stop everything, but those questions need to be asked, and the stop-start tool is actually quite useful. So definitely check that out.
Thank you for that, Ayat. Next, I'll move on to Sarwar for a few apps that he may use.
So I think a key app for those that's starting to work in hospital or primary care, Aiysha can probably tell me a little bit more about that, would be Renal Drug Handbook. This is an app that's sort of bread and butter to our role as hospital pharmacists. If you can look at the BNF and if you look under the kidney function section, that figure is the drug within CKD, the advice what to do. However, it's very limited information. A lot of the drugs that's within the BNF that states you can't use it under a certain eGFR, we can in fact use that same medication. However, we will have to reduce the dose of it. So Renal Drug Handbook, it's a website that sort of requires a login, so most likely you won't have access to it until you start your role, but it is one to get familiar with as soon as possible. We use it all the time and it is amazing. It's what we make a lot of interventions using this website, and we do make a lot of changes as well. Also, another key app to use in hospital would be new guidelines. So a lot of times in hospital, patients will be NG fed or have an NJ put in, or they'll have dysphagia or difficulty swallowing. So we use a website called New Guidelines. This also requires a login as well. So New Guidelines, essentially, it tells us a bit of information about if we can crush and disperse tablets in water, what we can crush and disperse it with, can we give the medication through a PEG feed or an NJ feed. This is quite an essential website as well. I think as a hospital pharmacist, you'll keep using this so often and you'll end up pretty much knowing you like the back of your hands for the most common drugs. Another key thing for people to be aware of when it comes to swallowing difficulties or if anyone's nil by mouth is Parkinson's medications. So a commonly used website by all hospital pharmacists and possibly primary care pharmacists as well is the Parkinson's Optimal Drug Calculator. So as you all know, Parkinson's medications are time specific. You need to have them at the certain time, otherwise the patient suffers from end dose drug effects. So what the Optimal Parkinson's Drug Calculator does is it's like a little calculator where you can put the patient's current Parkinson's regimen in, and it calculates if the patient can be transferred over to a patch if they nil by mouth, and it also lowers the dose as well if they have underlying dementia and whatnot. I guarantee you, as a hospital pharmacist, you'll be using this website at least twice a week. It happens all the time, and especially on calls. You'll get calls from doctors all the time about this as well. I'd be interested to know if Aiysha also uses these websites I use in hospital in primary care.
Thank you. That actually ties us into the next speaker, and hopefully Aiysha can walk us through some of the apps or websites that she uses in primary care.
So I think Ayat and Sarwar, between the two of them, have covered a lot what we do in primary care. Right Breathe app is fantastic. You can use that all the time, especially when you're getting asthma clinics. You've got a lot of COPD reviews, and then you've got your stop-start tool. Honestly, I've had this on hand, downloaded the PDF on my phone since the start of pre-reg, and I'm still using that daily. And Sarwar mentioned some really great ones there, the Renal Drug Handbook and Optimal Calculator. I go through these multiple times a day, let alone in the week. Just if you do end up in primary care, most practices tend to have the really big old renal drug handbooks actually on their bookshelves. Try and stick to the web page because it is obviously updated more regularly. And going on to new guidelines, this one made me laugh a little bit because we love this in primary care. I have never seen GPs so happy about anything like when they do with new guidance. Things are changing all the time. We have shortages. You've got patients who have long-term conditions that affect their swallowing. You have children who can't take tablets. You have elderly patients who struggle with lots of tablets, might want a liquid. Now, New is your go-to guide for this. Secondly, I, myself and my colleagues, we work really closely with our community pharmacists and our hospital pharmacists. So when there are national shortages, we try to stay on top of this, and we see if we can't do mass switches, because obviously you don't want to do a mass switch and then cause another shortage. We try to see if we have alternatives. Can you crush a tablet? Can you not? And this is where we check here, and we'll see whose medication we can crush, whose medication we can switch to a liquid, and then we liaise with the community pharmacists, or we liaise back with the hospital pharmacists to make sure that they know if they do a discharge to us, they can add that in the notes, and we will remember that we've actually told them we can switch this to from a tablet to a liquid, or we can crush this. Some other tools for primary care, and I think these are quite useful with the others as well. They could correct me if I'm wrong, but one is the FRAX tool. So this is by the University of Sheffield. What this app does is actually a website. You can get an app, but the website is more efficient as it's directly to the university. It calculates the chance of you having a fracture, or the risk of you having a fracture, and leading on from whatever the patient's score is, you're able to provide lifestyle advice such as exercising, quitting smoking, limiting their alcohol intake. And then if it's more long-term treatment management, you can figure out what bone protection is needed here. Now, this is medications such as bisphosphonates, which of course you all need to revise for your pre-reg exam and for your very first days provisionally registered. What I will tell you here is I'm very glad I revised the side effects for bisphosphonates, such as jawbone deterioration and the more serious side effects with those, because in a week I'm asked this so many times, and now it's just at the back of my head. Another site is MD Calc, so you can calculate creatinine clearance off here, which is really useful because anticoagulants there's like a lot of national projects with anticoagulation in primary care now, and MD Calc allows you to calculate the creatinine clearance, and I actually have found that it's a little bit more beneficial than the systems that we use because they can play up a little bit. A good tip I would give you all is if you are going to primary care or if you're going into hospital, bookmark the local formulary on your phone. There's been so many times I've not been able to get the internet on my system or the computers, and I've just gone onto my phone and I've been able to check and let somebody in the team know who's inquired that, or if I needed to know that. And I know on primary care, but an app that I have found very helpful is the OTC consult. Now this goes over like general conditions like hay fever, acne, and say somebody sends a task query through, so one of the doctors messages through a query, or if a patient rings up to speak to us, say for example they've acne, I can quickly check on there and it gives me some lifestyle treatment using mild soapy lukewarm water. And then obviously we know medications, there are restrictions on what we can give and what we can't give. Some things are better for patients to just buy. As with everything, there are factors to take into account. You can't just give a prescription for everything. So when I have had patients, for example, with acne, I've been able to check there, this benzyl peroxide, okay, that's a P medicine. I know they can go to the pharmacy and then speak to the pharmacist and get that. And I can liaise with the MDT, make sure they're aware of that, because costs with drugs like this, it's more costly for the NHS than it is for you to just go and purchase that. I'll pass that on to Usman now. Thank you.
Fantastic, Aiysha, thank you. We've had quite a lot of apps and websites to do with hospital and primary care. Now I'm going to ask Nabeel to talk a bit about community.
Right, so I just want to touch on what Aiysha just said as well, which was, she's mentioned the OTC consult, which is a brilliant tool as well. And again, it really does help from a community pharmacist perspective and being the hub of the community to be able to understand and deal with these minor ailments. So you're taking off the pressure and the burden of the off the NHS generally and of primary care as well. So something that can be treated over the counter, you're taking that into your own hands, and you are providing that advice to a patient, and it is a useful resource in regards to that as well, which is brilliant. And like she's mentioned, there is in regards to minor ailments, a lot of GP practices have limited their prescribing in regards to these self-limiting conditions, and so that really gives a community pharmacist, it really empowers community pharmacists to take lead on this as well, so we can diagnose these self-limiting conditions and hopefully provide lifestyle advice and over-the-counter treatment as well, which is brilliant. Another few things I want to touch upon just in regards to community pharmacy and some of the applications or guidelines that I come across as well that I've used fairly frequently. The main one is the BNF app. Download the BNF app on your phone. It is a lifesaver, and it is so much easier to navigate through compared to the paper version. And bear in mind, it is up to date because it's an application opposed to the printed copy. The BNF app, it has the treatment summaries on there. It's got individual drug monographs on there, and it's also got the interaction checker, which is brilliant, especially depending on how busy the pharmacy is and depending on the workload on the day. I think it is brilliant. You can just plug in names of specific medication, and it will tell you if there's an interaction and tell you what the interaction is, so you can make that informed decision on what you need to do next, whether you need to query it with a GP, or you need to speak to someone about it, or if it's just something like you need to inform the patient to look out for in regards to signs and symptoms, and to report it if it develops or if it gets worse. Another thing which is probably bread and butter to community pharmacy is the MEP. It's worth signing up to the RPS and obviously having a membership with them so you can access the MEP as well, because bear in mind, this is the legislation that we use in community pharmacy as well. So all the guidance in regards to responsible pharmacists, what you can and can't do when the responsible pharmacist is signed in or if they're absent, and what the pharmacy team can do as well. And it's a brilliant resource in regards to that. And I definitely suggest that you look over that in regards to your revision for practicing as a provisionally registered pharmacist, and obviously in regards to your exam as well. And the other thing I'd probably suggest as well is familiarising yourself with over-the-counter medication. The best way to do this is by reviewing individual SPCs in regards to these over-the-counter products. The reason I say this is because pharmacy line medication, they all have a licensing that allows them to be supplied over the counter, which is what the manufacturers put into place. An example is like clotrimazole and the age requirement. You can't sell to someone that's under 16, and you can't sell to someone that's over 60, or patients that have got diabetes or uncontrolled diabetes or any underlying conditions, etc. So it is worth familiarising yourself with these resources as well, and it really does help you in regards to knowing whether you can supply medication to a patient or whether they need to be seen by another healthcare professional.
Thank you for that, Nabeel. The next section that we're going to move on to is the support structure that will be in place for provisionally registered pharmacists. And I'll ask Nabeel to carry on speaking on this topic, please.
So yeah, just a quick one in regards to the support structure. So as a provisionally registered pharmacist, regardless of what sector you're going to work in, the GPHC have made it clear that you will have a senior pharmacist as a point of call or point of reference. So it is worth understanding who your key contacts are. So if you're in community pharmacy, regardless of which organisation that you're in, you need to find out who this person of contact is and have conversations with them. Figure out where your competence lies and what you're happy with and what you're comfortable with as well, and sort of formulate a plan going forward as well. And obviously know that you can contact them in scenarios where you're unsure or if you need further advice on what to do next. They are there for a reason, and it is a brilliant resource to have. With someone having another pharmacist there that's got more experience within that same sector. The other thing I'd probably suggest is again in hospital as well. You'll have a senior pharmacist that you'll be working with. You won't be thrown in the deep end straight away. You'll have someone that you'll be shadowing initially, and you'll be able to work alongside. And in hospital as well, there's always a senior pharmacist that has specialised in a specific area. And so if you've always got a query in regards to, let's say, renal medicine or something to do with cardiology or surgery, etc., there's always a pharmacist that has worked well within that area and has developed their knowledge quite well in that area that you can always refer back to. So it's always worth knowing who these specific people are, so you can sort of point your queries in those directions. And it's always worth knowing that there always will be support available, whether that's in the form of support groups on WhatsApp or Telegram, etc., especially with senior pharmacists as well. So, and it does seem like a safe space to have these conversations where you can explore different ideas, and you can also share your experiences with other pre-registration pharmacists as well. Sorry, provisionally registered pharmacists. So you can all benefit from one another.
Thank you for that, Nabeel. The next section I want to talk about, and this is key for preparation towards being a day one pharmacist. I'm going to pass that over to Aiysha and Ayat, and I want them to talk about the organisation that you can put in place.
So in terms of organisation, there's 4 main things that I would recommend quite quickly just off the bat. So first thing is get a diary. I can't stress this enough, especially if you're working in a variety of stores. So if you're in community and you're working in a variety of stores, which I believe some relief jobs are out there for provisionally registered pharmacists, it just helps to know where you're going and to plan your timetable essentially. Also in hospital, it's very useful. I use this daily because we have a lot of shift patterns. It obviously depends on which hospital you go to, but if you go to a large teaching hospitals, the chances that you'll be doing a variety of different shift patterns, so that could be on call, weekends, 2 till 10s, it varies, so it helps to just have it down on paper. The other thing that I would say is having a personal folder. So I personally have 2 folders. So I have a day folder that I carry with me on the wards. It's an A5 wallet, so it's just kind of easy to hand. And that I benefit a lot from that because I have a lot of resources that I use quite regularly in there to hand, which is useful while you're on ward round or board round or in MDT, because you just kind of have the information there. I will stress it's not realistic to assume that you will know everything, because that's not going to happen. So you can very, very easily say, I will check this resource and I will get back to you. I think there was also a question about someone published a question saying, what do you do if you need to check a resource in front of a patient in community? You need to remember that you are the responsible pharmacist. So any advice that you give out is going to be on your back, so to say. So you need to make sure that that advice that you're giving is first of all safe. It's not about how quick you are. It's not about how efficient in terms of time you are. That comes with experience. Anyone that tells you that you need to be quick on the first day is not being supportive enough, in my opinion. You need to take your time, check your resources, and you also just need to communicate that to your patient. Most patients are completely fine. They will be more than happy for you to check your resources and get back to them. So communicate that, take your time and have a bit of confidence in yourself and go from there, basically. So that's the one thing I would say. So in the personal folders, I tend to have antimicrobial table of activities. I have my handover, key resources such as IV guides. And in community, I have my responsible pharmacist sign, my MEP and EHC Fraser guidelines as well, which is quite useful. Not the full list, because that's like 96 pages or something ridiculous, the compiled version. But yeah, something like that you can kind of go on. If you're on call, which I don't think you will be on call straight away. For me, even as a newly qualified pharmacist, I only started being on call from January, so you won't need to worry about that very soon. But when you do start to become on call, have a folder with all your resources in. This one will be much bigger because the amounts of questions that you will get is incredible. But that is very useful to have. Also, just make sure to keep checking if printed copies are up to date as well. So a lot of times guidelines will be published again, or they will be updated. So just make sure that you're checking regularly. I usually do it on a monthly basis, really, and just check that everything's up to date. I would also say make notes of your usernames and passwords. If you're going into primary care or hospital, or even in community, you will be given new passwords and new usernames for a variety of softwares and things, essentially. So it's important that you keep that all written down.
Thank you for that, Ayat. Just passing over now quickly to Aiysha to add to that.
I know. Thanks, Usman. So I just want to say, I know we keep going over what's useful, what you'll miss out, but can I please just put this across there? You are important to wherever you're heading into. You are important right now. Make sure you have your support systems in place and look after yourself. That is so important. And I know that myself, I went into primary care as the only newly qualified pharmacist, and it was daunting. And I can't imagine how it must be for all of you who are going as provisionally registered pharmacists. So what I will say is, make sure you're comfortable, get the contact details for people who are managing you. Now, this isn't just in primary care, this is hospital and community. Make sure you know who you are shadowing, who your area managers are. Get the contact details for your senior pharmacists, your mentors and your tutors. And just make sure you check these are all up to date. And as Ayat said, make sure your printed rotas are up to date and in your timetables. Update anybody's contact details and get their numbers in advance. Emails, contact them beforehand. Join your practice hospital community WhatsApp groups if you have, and there's also lots of general pharmacy groups on Telegram for different organisation and general just overview for everybody to go in to get some support. And I can't stress this enough. It is all amazing having all these resources and these support systems out there, but not everybody's going to feel comfortable with that. So please have your own personal network of friends to tap into for support. I have found this so useful, being able to have that safe environment. I can ask questions without feeling like, oh, they're going to think I should know this, and never be afraid to ask anything. Nothing is a silly question. We are all here to learn. So yeah, I'll just pass that back to you, Usman.
Thank you, Aiysha. The next area we want to cover is the appropriate use of social media, and I'm going to pass that over to Ayat.
So very quickly, I won't dwell long on this, but essentially we just wanted to say a quick line in terms of appropriate use of social media. So presence on social media is encouraged, actually. It's a good way to network. A lot of your pharmacy news will come there. Jobs might be advertised on there. And I mean, pharmacists are very, very commonly known to be on Twitter, and there is a lot of things that you can learn from each other as well. So we'd never discourage someone to not be on social media. However, your public profile must not jeopardize your character. So avoid profanity and insults. If it's a public profile, just have in the back of your mind that you are a pharmacist, and a lot of other pharmacists and employers will look at your profiles. So that could be Twitter, LinkedIn, anything like that. If you have a private profile, then of course that's no one's business, and you can do whatever you want on it. However, your public profiles, we just wanted to put a quick line out there and just say, just be a bit wary of what you put on. But we do encourage people to network on social media as much as you can.
Thank you for that. Some essential information there. The next section of the webinar we're going to move on to now is, what does a typical day as a pharmacist look like? And the first sector I want to go into is hospital, and I'll ask Ayat to speak.
So in terms of what a typical day for me looks like, essentially when you're going into hospital, first of all, during your induction period, you will have shadowing on wards, a lot of validations that you'll have to do. So that will be dispensing, checking validations. You may have to do some proficiency tests just to check that you're okay with screening charts. Usually that's a minimum 2-week induction. So for those that are going into hospital, don't be too worried about being prepared on your day one specifically, because you will get a lot of training and you will have an induction period. However, when it comes to your day one on your ward, I thought it'd be quite useful just to quickly talk through a day-to-day life as a newly qualified pharmacist, just so it gives you a bit of insight. So typically I try to get into work 15 minutes early, just to scrub up if I'm on COVID wards, check rotas, check the bed states and the on-call log. So the on-call log is a log that tells you about any calls that your wards may have had overnight. So for example, if I'm covering respiratory, I will check the respiratory wards and just check if anyone's called overnight or anyone's been very sick overnight and they've needed some pharmacy input. It's also a good way to communicate with each other with the night team. So I prepare my handover. I'd head to the ward. It's very important on your first day, and even throughout your first week, introduce yourself as much as you can. The main people that I would say you need to introduce yourself to is the nurse in charge, the discharge coordinator, and the doctors. So establish what consultant teams are covering what patients. This just helps you to kind of get your queries addressed in the right way. So if you have anything in terms of a patient query, you know who to go to. This is very difficult on the first week, because a lot of times there is way too many doctors on the ward and you are kind of the only pharmacist there. So don't be too worried about getting to know every single person on the day one, but do your best to just introduce yourself as much as you can. So I would check the pharmacy diary, which is essentially where the nurses will communicate with you in terms of urgent medication requests, any discharges that need to go home, any new patients that come in. In terms of prioritization, you need to prioritize the newer patients and the sicker patients. So anyone that is particularly sick needs to be prioritized as well. And your discharges tend to come later on. However, if you work in a very busy hospital like I do, discharges tend to be a priority as well, because we're trying to push people out because of lack of bed space, essentially. But that does not prioritise over sick patients.
Thank you for that, Ayat. I'm just going to ask Sarwar, who has tons of hospital experience as well, to talk about MDT and why that's important.
So, yeah, I think MDT is very important in all sectors, guys, especially in the hospital. The future of pharmacy is developing into more of a clinical role, and for us to develop this clinical working role, we need to embed ourselves and integrate ourselves into the MDT. The reason for that, I think, is you learn so much of different professionals, and being within an MD team and working closely with clinicians, nurses, physios, dietitians is essential for the growth and development of any pharmacist. So my first time seeing a pharmacist really doing MDT is Mohammed, the gastro pharmacist, when I was doing pre-reg. He's listening to this webinar right now, and I would say if I could be any pharmacist, it would be like Mohammed. He was on the ward rounds. He was a key player in the ward. All the nurses went to him for support and advice, and patient care was vastly improved on his ward. So my advice for those working in hospital, and this is what I do myself, each day, if I've got one ward, it's a lot easier to do. Obviously, if you've got multiple wards, it becomes a lot more difficult. But straight away in the morning, what I'll do is I'll attend the board round in the morning. So in the board round, we have a big chart up on the wall with all the patients. We find out who's new to the ward, who's high risk, who needs discharging, any issues overnight. And as a pharmacist, being on that board round, you can highlight pharmacy issues straight away. You can put your input there straight away. You can help prioritize your ward day as well. Also, a key thing for pharmacists, please do this if you're a hospital pharmacist. Do not be shy. Do not be that pharmacist that works in a little corner and gives a job list to the doctor. Join the board rounds and join the ward rounds. This is where you will learn. Before I started my gastro rotation, I wasn't too familiar on liver diseases and gastro. So what to do is join onto the ward rounds, because this is where you're going to learn a lot from the consultants and the doctors. I always feel like when a pharmacist is on the job ward round, things will get sorted straight away. So before something gets prescribed incorrectly, if you are on the ward round, you'll get it sorted then and there. So it's important for your development and your learning. Also, as a ward pharmacist, you'll learn to work very closely with your nurses to help them and help your ward managers as well. It's also important, you will have tough days onto the ward, and what you need to do is with your ward, you need to debrief together after a tough day if patients have passed away and things like that. Also, another key thing is if you do MDT working, it'll help you on your on-calls as well. A lot of times the doctors or the nurses calling you, it'll be ones that you know personally, and you can resolve issues a lot quicker as well. The pharmacist's input into the MDT is essential. Me on my ward, I'm essential for every single medication that's prescribed and every single bloods, treatment, high-risk medication. And me being embedded into that team, I've noticed my learning has definitely developed, and also my training has developed, and patient care has definitely improved on my ward. Also, another way to get embedded into the team a little bit more is bring some chocolates here and there as well. The ward loves it, and you'll get coffees made for you all day as well. I'll pass it back on to Usman.
Thank you, Sarwar. Next, Sarwar briefly touched on it. We want to talk about on-calls because we've been receiving a lot of questions based on on-calls. So I'm going to ask Ayat to briefly speak about the experiences that she's had with on-calls.
Yeah, so in terms of on-calls, like I said previously, just get to know your shift patterns. You won't really need to have to worry about this too much. So if you are currently worrying about it now, please put it out of your mind. You will receive plenty of training prior to starting on-call, and no hospital will ever let you do an on-call shift if you don't feel 100% ready for it. So don't worry about it. There is a good support system in every hospital that you are in. It is high pressure. I'm not going to sugarcoat it, but you do, like I said, you do receive intensive training. On average, I receive about 70 to 100 calls a night, and my shift patterns is from 4 till 12 p.m. in the hospital, 12 a.m. sorry, and then after 12 we take the bleep home till 9 a.m. So it is different for every single hospital. The range of queries that you'll get will differ as well. You will get after midnight tends to be more critical queries. No one will really call you after midnight with minor queries. It will be critical care. It will be neonatal units calling for IVs or calling for compatibility queries. So they are very daunting. Like I said, I'm not going to sugarcoat it, but you do receive an immense amount of training and you will feel ready for your first one. So please do not worry about on call. It's the least of your worries right now. Just focus on preparing yourself for day one.
Thank you, Ayat. Going to pass over to Sarwar. Maybe he has some stuff to add to his on-call experiences.
Yeah, so on-calls are very daunting. No pharmacist likes the time when the on-call comes around. So mine is very different to Ayat. My on-calls aren't as frequent when I was doing them. They tended to be one on-call every 6 weeks or so, and you could do your on-calls from home unless you got called in. Luckily for myself, I only lived close by, so it wasn't too much of a problem. I want to reiterate what Ayat said. On calls, you can get anything and everything. So my first on call as a newly qualified pharmacist, I got neonatal TPN issues. 4 a.m. in the morning, I got woken up with clindamycin toxicity in ICU. I think it's very important to know that you do have support available when you are doing on calls as a pharmacist. You have your senior pharmacist you can discuss with. And also don't be afraid to say, I'm not too sure the answer right now. Can I take your number and I'll ring you back? Okay, so that's my biggest advice I can give for those that will start on calls. Know your limits and say to the doctor or say to the nurse, I'm not too sure of the answer, but I'll get back to you as soon as I can. This is essential to both safety net yourself and also give the appropriate, correct advice as well. I think just to reiterate that really, Usman.
Thank you for that, Sarwar. Next, we're going to move on to community and what essentially a typical day looks like as a pharmacist, and I'm going to ask Nabeel to speak.
Yeah, sorry, I just want to just touch on what Sarwar just said, just in regards to his last point in regards to safe, effective care, and obviously not rushing yourself. I think that's vital across all sectors, especially in the community pharmacy sector as well. Just because you will feel rushed, there are times where the workload will just pile up and you think you're drowning in work. So it is always worth speaking to, whether it's patient queries, whether it's phone calls, etc., taking the number and calling them back when you've got a chance to actually look into the query. If you're not able to obviously provide that the answer straight away, and again, it helps in regards to prioritizing your tasks and knowing what task is more important and which one can wait and which one you can get back to. So just going on to community pharmacy. So in community pharmacy, like Sarwar mentioned earlier, as the responsible pharmacist, you are that figure of leadership and support to the rest of the team. So yeah, it is worth, especially when you do end up in a community pharmacy on your shift, it's worth speaking to all the team, figuring out what everyone's roles are, figuring out what everyone is able to do in regards to their roles and what everyone is comfortable in doing as well. So there might be certain tasks that someone might be comfortable with or they might not be comfortable with, and it just makes it easy for you to obviously delegate tasks between your team as well. So it is important knowing that regardless of what tasks are piling up, it's worth knowing that you can offload some of the tasks to other members within the team. Effectively, you are working as a team, but you are that one person that is providing leadership within the team. So delegation is a key skill that you really would need to develop, as working as a day one as well. So because you're on the back end of your pre-registration year as well, it probably is worth taking on the opportunities to do so as well. In regards to community pharmacy, again, depending on the workload, depending on how busy each pharmacy is, it's vital that you take mental breaks. It's extremely important, just because you need time to switch off, to recharge before you go back in as well. And it is worth mentioning that to the organisation, to whoever you're booking, wherever you're working, to let them know that you've got, to ask them whether there is a protective mental break involved in your shift as well. And obviously not letting anyone rush you as well. SOPs as well, so whatever company you do end up working with, it's worth familiarizing yourself with the SOPs, this essentially is the way they want you to work within the pharmacy as well. So it is worth familiarizing yourself with them and sticking to them as well. Always keep an eye out for safeguarding issues and report them where necessary as well. We have had a lot of questions in regards to relief roles as well, and I can sort of relate to this as a locum pharmacist as well. What I tend to do is prior to a shift, I look at the route that I'm going to take to that store. I ring the pharmacy if I'm not sure about parking, or if there's any on-street parking, or if there is anything I need to do in regards to that. And it is always worth ringing the day before, just to get a handover from the pharmacist that's in that day as well, just to figure out what's going on as well. And punctuality is key as well. So this will help aid in that as well.
Thank you for that, Nabeel. Some excellent insight into community pharmacy. Next, I'm going to pass over to Aiysha for primary care.
So I think everybody wrapped up really well, all those different sectors. The one big shock you'll have in primary care, or the big change, and what I'll say is different to the rest, is there's no dispensing and checking in primary care and GP practices. And what you may envision to be the traditional role of a pharmacist isn't there. You do not spend all your time with the pharmacy teams as you may do in hospital or in community. It is MDT paced at all times, like multidisciplinary teams are core to all you do. So generally in a day-to-day basis, when you come in, you'd be checking your emails or tasks. Now, these are messages about patients on the systems that are sent through directly about a patient, or you may have something called notifications. These are an email system on the systems that we use, and you'll go through these, pick up anything urgent, and these could be from the doctors, nurses, from reception, from the neighbourhood teams, or sometimes from colleagues in community and hospital. Now, it's sort of up to you what you do with your day. It can be split how you want to. This is very much down to you and where you're working. So at the moment, I've tried to spend one day at each practice, and sometimes I split up my morning and afternoon between different sites if I need to. Again, no one day is the same. So I can't sit here and tell you this is what I do every day, because there is no one day that's the same. And I feel that seems to be across everybody who I've spoken to in primary care so far. So some days could be clinics, some could be in education and training, and others could be on research. There is amazing opportunities for research in primary care. This is because we do a lot of meds optimization, of course, and we do audits which involve searching. So we can search systems. So as I was saying before, you can be looking at patients who are on an NSAID, don't have a PPI, and just have a look at this as a whole and do a bit of an audit. And then you can follow up these patients. You can also see, for example, which epilepsy patients haven't been reviewed recently, or if there's any monitoring that you need to do, or liaise with the hospital or community pharmacy teams. And there's a lot of cross-sector working there. So it's not that you're in primary care and you won't have anything to do with other sectors. Evidence-based medicine is so important to support all of your discussions, because when I was in hospital, when I worked in community pharmacy as an undergraduate, you'd get a call or they'd ask you a question to give an answer, and then it's up to them what they do. But what I found in practice is when I give an answer, I need to be able to support what I've said and reference NICE or the European cardiology papers. And then I need to be able to discuss that, because you are so involved in that MDT team, and what you advise them is taken on board. So there is a lot of going forwards and backwards to ensure the correct decision is made, and you are involved in improving the long-term practice and clinical care of that patient, but the clinical practice guidelines that are in the practice you're in. So if you've said something, it's actually, this has been picked up and it's actually a lot more effective, it can change a lot of the guidance. There's also opportunities for education and training. So I've been involved in a lot of like education and training with GPs, nurses, the training GPs who come in. And this is to do with, say, drugs or clinical cases that may have not gone the right way because they've not followed updated guidance, or where there's been options to use better medications, or they've chose second line and should have been first line. A lot of antimicrobial stewardships here. You also are exposed to so many fantastic projects and working with teams in hospital, mental health and community. Some of the projects I've seen and I've been involved in is a national pharmacist-led AF project. So it's looking at people with underlying AF, and then we're checking their suitability to be put on a DOAC. DOACs are key, especially for your pre-reg exam. These came up in my pre-reg exam and in Nabeel's. So let's just keep that on board so what you are doing on your everyday basis in practice, it does help you for the exam. So just going on from that is, in primary care, depending on where you are, what your practice wants to do. If you're a practice-based pharmacist or a PCN pharmacist, you could be doing specialist clinics. These could be on different areas. You could be looking at medication and prescription queries, advising on medication. You can sometimes be involved in differential diagnosis. This is really great if you're doing your master's or your CPPE program. I've been able to have some really chunky case-based discussions because I've been involved from the start to the end. You get queries from the MDT team. You can help with triage queries from patients. What is different here is in hospital, I'd see a patient on a bed in a ward, I'd walk off, I might not even see them. In community, you're so busy and it's hard to get that patient contact. In primary care, you have face-to-face, you can have your virtual reviewing their records, you can give them a telephone call. And during COVID, we have had the luxury of trialing out remote video calling. So you can video call patients at home, or we've been really involved with care homework. You can video call the care home and look at a MAR chart that's to do with the patient's medication. So I'm personally finding the world's my oyster in primary care. Some of the clinical areas are falls, cardiovascular, care homes, like I said, being involved in some palliative work, pediatrics, mental health and neurology. Now, please don't get scared by all of the different things I've said. Primary care, you do become a generalist from the start because there aren't rotations to ease you into each area, but you have the luxury of this supportive MDT team. So reach out. Now, we keep saying MDT, but it's so pivotal to all that we do. And I think generally going forward as well, as the NHS and community, everything, we need to all work together as a team to get the best out there for our patients. Now, also don't worry if you get asked a question, whether it's your first day, whether it's your 10th day, or if you're 5 days in or 6 years in. I've spoken to senior pharmacists, nobody ever just gives an answer on the spot. You have access to resources and guidance. We have specialists where we're needed. We have the mental health liaison team. We have consultant pharmacists from the hospital who we can work with. We have specialist GPs who actually also are consultants at the hospital who will split their time over. So you have a fantastic team around you. You're never alone. And if you don't know anything, don't be scared to say, I will get back to you. Unlike hospital or community, you don't have to get onto it straight away. Usually there's nothing critical that is coming through to you. If there is, you still have like an hour or two to get through. So you can check your guidance or tap into your support network or your MDT team. I hope that's helpful. I will pass that back to Usman.
Thank you for that, Aiysha. Some excellent insight into primary care. Next, we're going to move on to the final section of the open discussion. And then hopefully after that, we'll move on to the question and answer session. I know a lot of people are waiting for us to move on to that. We are aware of the time, and we'll go through this next section as quickly as possible, hopefully. And this next section will be based on what we would advise for maintaining and developing knowledge during your provisional registration. So keeping in mind that pre-reg exam. Firstly, I'll ask Nabeel to speak about difficulties that may come into contact, based on local guidelines and evidence-based medicines.
Right, okay, so in regards to local guidelines, etc., I found it slightly difficult initially when I started my revision for the pre-registration exam, just because I was so accustomed and so used to the local guidelines that we followed, and especially in regards to antimicrobial stewardship and obviously the guidelines that we use. So a lot of the first choice, the second choice was all based on local sensitivity reports, local resistance reports, etc. And that's what influences how local guidelines are created. So for the exam itself, I would suggest reviewing CKS, so clinical knowledge summaries on NICE, and sticking to national guidelines, especially for the registration exam as well itself. It just makes it easier that way. Because in hospital as well, we do tend to see a lot of off-label and unlicensed use of medication as well. I'd probably suggest sticking to what you find in the BNF and obviously the indications that you come across in there as well, especially the non-unlicensed uses and off-label uses as well that are mentioned in there. They're probably worth looking into and looking over. And another thing I'd probably suggest in regards to provisional registration, because you will be essentially sitting a registration exam at some point, it is worth staying on top of your knowledge. Obviously, it will benefit you in practice as you practice, and especially obviously towards the exam as well. And a lot of people have messaged us from our group chats just in regards to this, because they think that because you're working, you don't have the time to revise. What do you do and how do you overcome this? So my piece of advice for this would be, so let's say if you're in a community pharmacy setting, when you're reviewing prescriptions, have the BNF app open as well. Review the indications for specific medications, especially those that you're not too familiar of, you're not massively aware of. Have a look at that and look further than that as well. So whether the doses match the indication, and then look into it further in regards to renal impairment, hepatic impairment, or if there's any specific side effects that you could potentially counsel a patient on there and then. These instructions will enforce your revision and your learning as well, and it will stick to your memory a lot easier than just rote learning as well. So I think it is a brilliant opportunity to be able to practice and revise at the same time. And again, you can do this across the board regardless of what sector you're in as well.
Thank you, Nabeel. Next, I'm going to pass over to Sarwar, and hopefully you can walk us through how to take advantage of opportunities you may have to learn in practice.
Okay, so first of all, we just want to reiterate what Nabeel said. It is essential to keep on top of your knowledge because there will be an exam, and also because as healthcare professionals, as a pharmacist, it is part of our framework to maintain your knowledge and maintain CPD and continuously be studying as well. So a key thing is to maintain knowledge, I would say, is if you are short of time, what you can do is listen into clinical podcasts. And this is something I frequently do. So I know a lot of people may be commuting to work and whatnot. There's tons of clinical podcasts that you can listen to that will benefit you in practice and for the exam as well. Also, it's imperative to learn from others as well. So if you're in a hospital, try learn as much as you can from those you're working with. So consultants, nurses, specialist nurses and whatnot as well. Another key thing Ayat and Aiysha mentioned as well earlier, the importance of being on social media for pharmacists. I think social media is a fantastic tool to network, to develop, to just keep up to date, really. What you can do on Twitter and whatnot as well is follow some societies, so Cardiology Society or Gastro Society. This will help reinforce your knowledge as well, because you'll always be continuously being up to date with the latest guidance as well. And as Usman said, how to really reinforce learning when you're checking something is what Nabeel really mentioned. If you're unsure of something, or you've seen a drug that you've not seen before, or you've seen therapy that doesn't really make sense combined together, go on to NICE guidance, go on to guidelines, have a look. What is the current guidelines? What is the latest guidance? Everything's continuously changing for the better of patients. And us as healthcare professionals, it's essential for us to ensure we're up to date and always doing the best we can to maintain our knowledge to give our patients the best care. Back to you, Usman.
Thank you for that, Sarwar. Now, finally, we've concluded the open discussion and we're going to move on to the PharmaSense webinar Q&A session. We've had plenty of questions that have been sent in beforehand, and hopefully we should be able to get a few of them, and some that have been sent during this webinar. A lot of the questions have been answered throughout the webinar through various sections by the speakers. So hopefully we'll get cracking with that now. And the first question I'm going to target towards Ayat, and that is, how does one start to apply for different positions?
So in terms of the applications for different positions, it depends entirely on which position you want to apply to. So if you're going for anything hospital or primary care based, the best place to start is NHS jobs or track jobs as well. Also on LinkedIn, so a lot of jobs are advertised there. These are the places where, if you think about any place that is going to be employing you as an NHS employee, it will be on NHS jobs, and all you have to do is kind of search by location and search by the keyword pharmacist, and it will tell you whether it's a band 6 or a band 7. And it's quite thorough there in terms of what requirements are needed as well. So just search and apply, ensure you read the requirements beforehand. Most NHS jobs will require a supporting statement. This is an opportunity for you to showcase your skills, discuss the interventions you've made and any additional experiences that you may have, such as volunteering, publications, audits, anything like that as well. So that's where I would start with. There is another question later on where I will discuss about the interview techniques as well, but I will pass that back on to Usman for the next question.
Thank you, Ayat. The next question will be, Will you be eased into clinics in PCN? And I'm going to target that one towards Aiysha.
Thanks, Usman. Can I just add on to what Ayat said about jobs? I have published one of the questions that came through about how do newly qualified pharmacists apply to primary care. So if you just have a look there are some of the different titles that you might see. So if you've not applied here before, these will be quite helpful for you to just have a quick glance at. So how will you be eased into clinics and primary care? Please don't be scared. I was quite nervous when I started because, as I said, I was the first foundation pharmacist and it's a whole new world. But it's amazing because you have such a fantastic support network. They have a fantastic induction program for you. It's very structured. You will usually be contacted before you start to get your settles in. Once you start, you have this very easy laid into induction period with different members of the MDT. So don't be afraid if you're not spending a lot of time with the pharmacist. You will learn the same from the pharmacist that you will learn from the doctor. But if I'm honest, I probably learned initially a lot more from, say, reception and admin because they know the system so well, and I feel systems are trickier than anything else. We have the clinical knowledge. You are all MPharm graduates, so don't worry too much there. There's guidance there. Spend your time practicing with the system and shadowing. Make the most of your induction period. You will be eased in as much as you want to be eased. If you want your induction to be sped up, you can work with them, and if you are competent, they will do that, but it does very much go at your own blow. If you're new to primary care and GP, again, please don't worry. You have a senior pharmacist and the GP is usually assigned to you, and they are there to mentor you. So be that about where to find clinical guidance. If you're a bit worried about seeing your first patient, you want to shadow a few more times, or if it's just to find out where's the nearest place that you can get a fish and chips from, they are fantastic in that sense. The IT teams, please make the most of them. They are all in their details will all be in your induction, and they will help you ease into PCNs more than anything. Get your head around the IT systems and you will feel at ease straight away. And another thing that's really good with easing you into PCNs, because please don't be afraid to start alone as a provisionally registered pharmacist. You won't be alone. Like I've said, you have this team, and you don't just have the practices that you're based in. You have this wider team. You have the neighbouring practices and neighbouring PCNs. You have the CCG commissioning team will support you if you need any help to do with like budgets. You have the clinical pharmacist teams and neighbouring neighbourhood teams, Confederation teams. So I guess the key thing I'm trying to get across is you're not going to be left alone or in the lurch. You're just left there and expected to know everything. You are eased into it and it will go at your pace. So just put your voice out there if you need extra support. Back to you, Usman.
Thank you, Aiysha. Next question, how do I get a role in hospital if I've only worked in community and GP? So I'm going to target this one towards Ayat.
I've had a lot of questions like this. So I need to make it very clear, it is not a necessity for you to have had a hospital pre-registration placement or a hospital placement anyway, because I know a lot of you have lost that due to COVID. It's not a necessity for you to have that to apply to a hospital position. What I will say is that hospital interviews typically follow a very similar structure. Just for in terms of background, I've done a variety of hospital interviews across the country and they've all been very similar. So typically you will be asked to discuss interventions. Now the interventions need to be clinically significant. So a lot of you will have already been doing evidences throughout your pre-registration year. What I will say is maybe go and review those evidences and pick out 1 or 2 interventions that you think are clinically significant. So something that you have done as a pharmacist that has contributed to that patient's care or has prevented a harm or a near miss from happening to that patient. You'll be asked to discuss this in detail in terms of resources you may have used. If you haven't used any resources, think about what resources would have been beneficial to look at if you were to go back to that time. So definitely number 1 is interventions. Number 2, you may be asked to do some drug chart screening or a maths test. The drug chart screening, do not worry too much about it. They are not there to test your clinical knowledge. They are there to test your thought process. So a lot of times they will ask you to actually talk out loud in terms of your thought process. So they want you to spot, have you checked for allergies? Have you checked that the drug charts are matching with other drug charts? For example, if a patient's got an insulin chart and a warfarin chart, do the names match up? Stuff like that. In terms of therapeutic drug monitoring, for example, if you see an aminophylline infusion, you're instantly going to be thinking, okay, have we taken levels? Is this toxic levels or not? So it's stuff like that. It's not necessarily testing your knowledge. You can easily say, I'm not sure about this, however, I would check in this place. The next thing is prioritization questions. More than likely, you will be given a set of scenarios. They might say that this is a scenario on call, or they might just say that you are ward-based, and it will be discussing a variety of scenarios. For example, you have a discharge script and you have a nurse on the phone that's asking about an IV for a young child. You then have a doctor who's querying vancomycin dosing. It'll be stuff like that, and you kind of have to prioritize, okay, what am I going to do first? Now, previously, like I said, you always prioritize the sicker patients. They are your priority, and then you kind of go down from there. So there's definitely going to be a prioritization question, and this is the aim of this is just to see your thought process and how you go about thinking about day-to-day tasks. Study the values of the trust and discuss how you will fit in as well. So every single trust will have values and standards. Study them, go onto their website, get to know what you're getting yourself into, and get to know the trust. Every single hospital trust loves their own values, of course, so you need to make it seem as though that you actually align with those values as well. In terms of another question that they might ask is in terms of never events as well. So never events are things that should never happen. So it's like maladministration of injectables, for example, if you're giving something the wrong route, overdose of patients who are opioid naive, so giving too much opioids. These are all never events. They might ask you, what would you do in this situation if a nurse, for example, administered too much opioid to a patient? Your main thought process around that, you would need to make sure that the patient is okay, establish why this happened, and have a discussion, a very open discussion with the nurse, and just to kind of talk about your thought processes there. But yeah, I'm happy to help on a one-to-one basis with interviews. Hopefully we will do a seminar more focused on interviews. It might be something that we could do in the future. But if you need one-to-one help, please reach out on Twitter, and we will be happy to do that.
Thank you for that, Ayat. Next question is based on community relief work and potential difficulties that you may find going from store to store. So I'm going to ask Nabeel to speak about that.
So yeah, it is difficult trying to go from store to store, especially when there's at each store there's an established team, and depending on how frequently you work for specific stores, you are effectively joining the team. You have to build rapport with them straight away, in a sense, especially with your team members. You need to have, by building rapport, you're building trust within the team itself, especially as a new member coming into the team. But that trust and that rapport is valuable in helping you to effectively do your role as a responsible pharmacist. So yeah, it is daunting at the start, but again, like I mentioned previously, it's worth getting to know every member in the team. Obviously introducing yourself, figuring out what everyone's roles are, whether they're a technician, a dispensary assistant, or if they can dispense, etc., and taking it from there. And again, figuring out what sort of workload that you're dealing with. The best way to probably do this is using a website called PharmData. You're able to see how many items a specific pharmacy does per month, and the sort of services that they do as well, and the number of services that they do as well. And again, that will help you to make a more informed decision on which stores you do work at, and whether you are comfortable in the workload as well. And again, each store is based on a different demographic, so have a look into this, speak to other pharmacists that have previously worked in those areas, throughout your support groups, and figure out what their thoughts were on that area, on that store as well, and figure out what they sort of either enjoyed about it, any advice that they'd give you on that, etc., and take it like that. As a provisionally registered pharmacist, you will the only option you've really got is is in regards to relief, and you won't be able to locum. So as a relief, you will have a coordinator that books you in your shifts as well. So it's worth speaking to them as well, and to figure out what areas you want to work in, what stores are available, etc. And you know, any concerns or anything that you want to highlight to them, or even if you've had a bad experience at one store, it's worth mentioning it to them. You know, if that's a store that you want to avoid going to again, or whatever, it's worth speaking to them about that as well, and you know, having a more sort of informed approach to doing so.
Thank you for that, Nabeel. The next question I want to move on to is, can we influence our learning during our induction? So I'm going to pass that over to Sarwar.
So when you say inductions, I believe you mean hospital, as that's the sector I usually work in. So hospital inductions, Ayat did go through it a bit earlier. So you can sort of influence it depending on what ward you wanted to start on. I mean, you can speak to your line manager and say, I really want to start on a surgical ward first, or I want to start on a medical ward first. But it's important that you follow the timetable the hospital puts into place for you. It's a structured timetable. So Mohammed, one of the pharmacists, once told me you need to know all steps in the process. So the steps between procurement and to the patients being discharged and the handover to primary care. And this is what the hospital induction will do. So you know all steps in the processes. So when you are on call, you know what to do. However, typically you do have some sort of guidance if you want to do influence your inductions, in a sense. If you do want to start on a medical ward, say in your interview, say you're looking forward to starting on this ward or that ward, and that possibly can sway it. It's all about communication. Communicating with your line manager is important as well. Back to Usman.
Thank you for that, Sarwar. Now I'll address a final question that was sent through during the webinar. I think a lot of the questions that were sent through have been answered. If you guys can just look on the tab where the messages have been coming through. One of the questions that I thought was very good was based in community. So we talked a lot about the apps and websites that you can use, and a lot of patients that come in community aren't willing to wait, so to speak, and you tend to be in a rushed environment. So I want to target this one more towards Sarwar and Nabeel, and in terms of what techniques do you guys use to stall the patient and also make sure that you're ensuring the safety?
So in regards to that, sorry, so in regards to your question, so if I've got a bit of a manic workload at that present moment, it's worth figuring out which query is more important and taking it from there. So again, like the example we gave previously, if there's a patient in front of you that's there in the pharmacy, it's worth speaking to them, or even getting one of your another member of the team to speak to them, and then obviously relay that information back to yourself and see what information they can gather before your input is actually given. And the other example is if you had a phone call and it was a query, you can always take the patient's number and write down the query and give them a call back when it's more suitable in regards to, you know, the workload and the time is, and obviously take that time to obviously make an informed decision. You know, look at relevant guidance, or you know, look at reference sources if you need to as well. You've got to bear in mind the patient safety is paramount as well. So working more towards a safe and effective way going forward is probably the best way to go about it. So again, it's more sort of figuring out your competencies, figuring out the competency of the team as well, figuring out what people can do within the team and how they can facilitate you know, your workload in a sense, and you know, sort of delegating the tasks to them as well. And then sort of if they've got any questions or queries, they can always refer back to the pharmacist. Sorry, just back to you, Usman.
Yeah, thank you, Nabeel. If I can just ask Sarwar to add to that.
Yeah, so of course it can be difficult if it's a busy pharmacy and whatnot, but first and foremost, it's your name on the wall. You are the responsible pharmacist. Patients need to understand what we do in our roles. We are checking that medication is appropriate, that medication doesn't interact with anything, the dose is appropriate. So I am comfortable myself stating to the patient, I understand you want this medication to be dispensed quickly. However, I need to make sure it's safe. It is my job as a pharmacist to make sure the prescriber has prescribed you the correct treatment and it is safe and appropriate for you as well. So I would not shy away for stating it to a patient that I am doing my due diligence to make sure the information is correct and the treatment is safe and appropriate for the patient. Do not let anyone rush you. It's your name on the wall, it's your registration on the line. We are healthcare professionals here to make patient care better. So we will take our time to ensure patient safety. Back to you, Usman.
Thank you for that, Sarwar. I'm going to ask all the speakers to issue their closing statements now, starting off with Sarwar.
Okay, guys, I know we've run a little over. I hope even if one of you've learned something from this webinar has been successful for me. So please, we are very proud of you all pre-regis. Keep up the hard work and always know we are here to support you.
Nabeel?
Yeah, just touching up on what Sarwar said, you guys have been invaluable, especially during this COVID-19 pandemic as well, especially the way you've had to adapt your roles, take on more sort of leadership roles within your organizations as well. And your pre-registration might not have gone the way you wanted it to go, but you've probably learned skills that a pandemic, you've probably learned skills that you wouldn't learn any other way. And again, you guys will be brilliant pharmacists. So if you need any support or anything at all, reach out to one of us or any pharmacist that you're aware of. We're all here to support you.
Aiysha? Aiysha, sorry, for a closing statement.
Hi, sorry. So I'd just like to add on from what the boys have really said, and really also just believe in yourself. Don't think you're a provisional registered pharmacist. You haven't sat the exam yet. You have graduated from your MPharm and you've done years worth of training. Try your hardest, work hard, reach out if you need guidance from your team, and if you need any support or guidance from us, just give us all an email or drop us a message and we are happy to help.
Thank you. And finally, Ayat?
Yeah, so I just wanted to say thank you to PharmaSense for facilitating this. I hope you've all gained something valuable from this session. Be confident in yourself. You've all got this. You've all made it this far, and you need to recognise that achievement, because that is an achievement in itself. So please reach out to us on PharmaSense socials and our individual socials if you have any further questions.
Thank you. Firstly, I'd like to say a big thank you to all the speakers for volunteering. We hope that this webinar has been informative and that we've answered your questions as clear and as direct as possible. PharmaSense will continue to support and mentor our pre-regis throughout this process. If you found this webinar useful and would like something similar in the future, please reach out to us via Instagram or Twitter. Thank you and take care.